Craving your next action-packed adventure? Audible delivers thrills of every kind on your command, like Project Hail Mary by Andy Weir, where a lone astronaut must save humanity from extinction, narrated with stunning intensity by Ray Porter. From electrifying suspense and daring quest to spine-tingling horror and romance in far-off realms, unleash your adventurous side with gripping titles that'll keep you guessing. Discover exclusive Audible originals, hotly anticipated new releases, and must-listen bestsellers that hook you from the first minute. Because Audible knows there's no greater thrill than the one that speaks to you. Discover what lies beyond the edge of your seat. Start your free 30-day trial at audible.com/WonderyUS. That's audible.com/WonderyUS.
I'm as mad as hell, and I'm not gonna take this anymore!
Welcome back to the show. My guest today is Charlie Coltman. He's an old buddy of mine from the Cancerverse, from varsity soccer to epic sales guy in the pre-internet world to his best friend died from cancer, and now he's an advocacy hero with a new company called Cancer Life. It's a mobile app that connects patients to each other and does really cool things in the diagnostics and self-reporting space and the jargon of patient outcomes, but it's nerd stuff, but it works. The show's not really an advertisement for Cancer Life. He's a great guy. He's just incredibly genuine, and we've been supporting each other for a very, very long time. He came to New York from Philly to join me here in the studio, and you know when you're friends with somebody and you don't see them for like 5 years and you see them again, it's like you never hadn't seen them and you just pick up where you started. That's this show, and I'm thrilled to have you guys check out our conversation. Enjoy the show. Charlie, welcome to the show.
Thanks, Matthew. It's been a little while.
It has been a little while. All right, let's bitch about stuff.
I'm in.
All right. I like the layperson, the fact that, healthcare is complicated and fucked up and stupid and built the wrong way, the right way by accident, and it wasn't really meant for the end user being the patient. But where I want to start is let's explain. If we rank stupid from like 1 to 10, I think 10 is the stupid of, 10 of stupid, is that pharma makes the drugs that people take, but pharma doesn't know who the people are that take the drugs.
Yeah, kind of stupid. I'm a company, I make billions of dollars, but I have no idea who my customers are.
Well, the customer is the doctor, right?
Oh, absolutely. And that's how it's been, since the beginning. And the question is, what's a better model? And why doesn't pharma recognize that, if I build a relationship with that end user, that patient, the patient will return the favor and share how their journey is going and how those drugs are working.
Yeah, but our devil's advocate, is that a safety issue if you trust regular people with medications, and do you need the arbiter of Hippocrates to govern that? And wherein lies the rub between the manufacturer with the product, the person giving the product to the customer, when the doctor's really the customer?
Yeah, and I think it's, everyone's trying to focus on the patient experience, but I think, patients, rarely have a seat at the table, and I think the best way that they can have a seat at the table is to contribute to the conversation, which is the data and how their journey is going, and what, is the treatment working is a really important question, and the doctor wants to know too. And if the doctor doesn't even know, because half the medications that he prescribed are not even picking up at the pharmacy, again, problem. And if anything goes wrong, don't talk to us, talk to your doctor.
Right, exactly. Yeah, but again, this is the age-old issue. If the manufacturer that makes the drug doesn't know who's actually taking the drug and or not, or yes, benefiting from it, this cottage industry crept up 20 years ago of how do we get patients to talk to pharma? And it's really still hasn't really worked, has it?
No, and this is also kind of a data problem, right? And as you know, I work in the cancer space. I'm not a cancer patient. But
not a requisite, by the way.
Well, listen, as much as I've been, my personal journey, losing my best friend to pancreatic cancer almost 11 years ago, started me on this journey of trying to improve care for patients. But to your point, Matthew, as I've said to you a million times, I've talked to 1,000 patients, but I can never know. I still don't know what it's like to walk in their shoes because every time I hear something that's shocking, something more shocking comes down the pike, especially with cancer. But here's a stat. Problems with patients and doctors and data, right? So the electronic medical record, they go in, you fill out your little form, you go for cancer treatment, and it says, how are things going? What are the symptoms and side effects? We fill out that little white paper form, you literally check everything and you hand it in. Well, that piece of paper is called patient-reported outcomes. There's nowhere for the electronic medical record to collect that data. Mary Sue at the front is just going to hand that to the doctor. The doctor's not entering that data. So in cancer alone, there are over 50 million encounters that are lost every year because that data has no place to go.
Because it's written on a piece of paper with crayons.
Correct, and thrown into the trash for all intents and purposes, literally in the trash. And either the doctor looks at that form and asks the patient a question, probably not, or the conversation is just lost. So the point is, it's also a data collection problem. So if pharma can't get to the data, what are they to do? And I think the answer, what we're talking about today, is called digital therapeutics.
On the next exciting episode of Out of Patients, what the fuck is a fax machine doing in my doctor's office?
Well, it's an app on your phone. And, when I started in this business, and you and I have had conversations about technology and folks suffering cancer. It's, there's obviously the stupid cancer population. The younger folks were more technically savvy back, 10 years ago.
Right.
All the rejections I got were, my mom will never use a smartphone. They'll never use an app. Well, guess what? 10 years later, fastest growing population, over 60% of seniors have a smartphone.
Right.
And guess what? They're on TikTok, they're on Instagram, and they're socially connected.
So again, we go back to the rub, which is that pharma, the manufacturers, I'll just call it the manufacturers, whether it's a therapeutic or diagnostic, they need to know who's on these products, who's taking advantage of these services. And the only arbiters who can let pharma know are the doctors if they fill out the forms. The patients have to tell them what's wrong with them. And we're going down the rabbit hole here of pharma doesn't know what's wrong with patients who have a problem with the drugs. It's not a one-size-fits-all. I mean, a whole other show on how nearly every trial is white people, like massive challenges in diverse communities. But it's like Toyota doesn't know if the steering doesn't work in your car. Right, like that. It's so ridiculous that that's the way it is.
Well, they know they have a registration, right? They have the registration that the car manufacturer the patient filled out. Here's my name, address, phone number, and there's some claims data, right? They can mine the claims data. And thank you, University of Pennsylvania, Cedars-Sinai. We need to understand what's going on, but a claim is only if the patient reported it,
right?
And it's connected to a diagnostic code, but it's basically registration versus how are you really feeling, and how are you really feeling not just now, how are you feeling 6 months from now? How are you feeling 12 months from now? How is the drug affecting you over time? And the over time point is also the big rub. Long-term patient-reported outcomes does not exist. And for something in cancer, which dramatically impacts patients' lives, not just from the disease perspective, but the symptoms and side effects associated with that treatment, the fact that it's not reported is a sin.
26 years ago, I'm out of Sloan Kettering. I'm trying to figure out my life again. And every couple of months, I'm living with my parents. And every couple of months, a letter comes in the mail from Sloan Kettering asking me how I'm doing. And I was just so angry in how I was mistreated, and it was just the worst experience ever. Maybe 23, 24 years old. And I wrote back, "Go fuck yourself" on every one of them and mailed it back to Sloan Kettering. I don't want to even talk to you about how I'm feeling. But if I had, like in early non-EMR days, just MR days, medical record days, Filofax Mad Men days, would that have even been helpful at all? Because I'm a moving target.
Now we're touching on something specific to cancer, which is the survivors out there, right? So in treatment, you're going through your cancer treatment, you hopefully get through it, and then what happens? And this is something I think you would agree with. The bullshit associated with ringing the bell, right? And yes, it's a great feeling, and it looks good on paper, and it looks good on videos that someone's ringing the bell. And we're all glad that patient is moving from active treatment to survivorship.
Right.
But guess what? Cancer centers don't care about survivors because there's no money in it, right?
Right.
They basically ring the bell, and they should just say, get the hell out, right? And now, other than a letter you might get in the mail every, I don't know, year and a half that says, you really should come back. We'd love to hear from you and do a diagnostic. The survivors who I deal with all the time are now dealing with treatment side effects, pain management issues, neuropathy. Chemo brain was not even considered a real thing up until a couple years ago when someone actually decided to do a study about it.
Now, that was a legitimacy campaign worth having.
Right. So the bottom line is, and that's patient-reported outcomes, that's long-term analysis and really trying to understand what are the long-term implications, not to mention trying to get patients back, starting their lives over, and beginning over. And that challenge from a mental health perspective is just underappreciated from the perspective of the cancer team.
I mean, would you agree that these are better problems to have? I mean, my get over it therapy in the 1990s didn't really work for me, but the whole idea of survivorship being something that could be a billable code was a new idea in 1998 when they had the March on Washington to get reimbursables for rehabilitation. Like, this is a real history note right here. We covered this in our documentary, The Cancer Mavericks. But, it couldn't call it rehabilitation because there wasn't a thing for that, right? There was no drug rehab yet at the time. It was the AIDS movement and breast cancer wars. But Livestrong, to their credit, I mean, you could slice and dice their reputation any way you want, but to their credit, they kind of tried to launch the first survivor care clinic at several hospitals with a basic standard of care of following up with patients as the idea of long-term survivorship, the gift that keeps on giving, was a really big deal. And it kind of flotsomed and jetsomed for a while, but it eventually became the idea behind, like, a Kevin Effinger. Give this guy huge credit. MD Anderson built the Sloan Kettering long-term survivorship care program. I was like target zero for them, like patient one for them. But it didn't really do anything to help me. It just probably gave a bunch of data. But there's no way to really know, is there?
Well, I mean, now you're touching on how care is delivered in America. We can be pissed about that, but it's really a location issue, right? Like, we're sitting in beautiful Lower Manhattan, New York City. There are, 3 world-class cancer centers within a quick cab ride right from here. 30% of patients are treated in these great university settings, and they do have the money and they do have the people to set up these programs. The other 70%, however, live in rural America. They have 3 oncologists. A lot of my patients that I engage with, their treatment is 3 hours away.
Right.
They don't have access to ask them where they're getting their actual physical rehab, like just on their shoulder versus, long-term neuropathy. So the point is, the bigger challenge for these patients is where they just don't have access. And access isn't because they can't afford it. They physically can't get to it.
Right. It's just geography.
Yes.
Pure geography.
Absolutely. And I mean, this is, we talk about disparities of care. It's not because they can't afford it. It's because the doctor is overwhelmed. 1 or 2 or 3 doctors handling every cancer type, right?
Right. In like half of Montana.
There are 30 cancer types, and other people say there are 300 cancer types. And they have to make treatment decisions for this population of people they live with. They're overwhelmed. The disparities of care can be, anyway, I could talk about how you can make better treatment decisions for these folks because you can use technology to do that. But the point is the delivery of care and the people, they just don't have, they don't have a Walmart clinic. If they do, they're not designed to handle everything like that.
You just penetrated the anger crust to the anger mantle of the earth.
And it's unfortunate, but, technology can help. Telemedicine, I mean, that if any population is standing up in the audience, clapping, telemedicine, being able to just check in with your doctor and to say, do I really have to come in 3 hours to see that you're just going to tell me, let's keep it on the current track? And,
no, there's no doubt that telemedicine, I've talked about telemedicine as like Amazon taking credit cards in 1999. No one would even remotely trust giving Amazon your credit card or eBay your credit card or PayPal in 1999. And today it's standard fare. So is it safe to agree that, I mean, the pandemic, if it did anything positive, it encouraged people to trust telemedicine for basic stuff? Like you can show a dermatologist something on your arm, you know, maybe there's, I have a fever, quick, but how do you do telehealth in like life-threatening disease?
Well, yeah, obviously, you know, especially for immunocompromised folks who are on some serious, you know, depends on the cancer, depends on, you know, the treatment protocol, but there are a lot of opportunities. And I think where it's going for rural America, the good news is with genetic testing, where things have moved from tissue-based genetic testing and biomarker testing to liquid-based, which means blood. If you can send a nurse out to do a test and see how the patient is doing and not bother them and having to come 4 hours, you'd send a nurse out there, pull the blood, and the doctor just connects with you and says, I'm drop shipping your new medication, and I don't have to go through a barrage of tests and even an invasive tissue-based test for genetic testing. That's fantastic. So there are things that are coming from a technology perspective, billing perspective, i.e. helping to pay for it, that delivery of care will be better.
So
for
cheek swab by drone.
Seriously. And I'd sign up for that versus driving 4 hours, paying for parking, waiting in the waiting room for my doctor just to tell me, good to see you, everything's fine, thank you very much. And the patient's going, I did all that for what? I had a lot of other things to do.
Before we go to break, tell me about your friend.
So my best friend, Chris Mattioli, I'm from Philly. He was the most engaging, amazing person that I've ever met. I used to joke with him that he was going to be the next mayor of Philadelphia. And he said, no, Charlie, I'm not running, but I'll be the guy behind the guy. He was from Philadelphia. He moved there. He was a bartender. If anyone's been to Barclay Prime, one of the best steakhouses in the city, he was the bartender going to night school at Temple University. He got diagnosed stage 3 pancreatic cancer in the emergency room.
Out of nowhere?
Out of nowhere. There were some indications that something wasn't quite right, but literally, and that's unfortunately for pancreatic cancer, that's kind of how you get diagnosed. You get jaundice. The tumor blocks the bile duct and you literally have yellow eyes. And that's what happened. And what the sadness of the story is that he was given the best care in the world. Jefferson Health System, Charles Yeo, who invented the Whipple procedure to remove his tumor in his pancreas, did the actual procedure, came down from Princeton. He was actually billboard in New York City as part of a New York Times campaign saying you can work through this. He worked. However, he transferred his care up after about 18 months and transferred his care up to a small hospital closer where he lived. And essentially his doctor treated him till death. He was on Tarceva. He lost a lot of weight and he died in the emergency room.
Wow. No
goodbyes. And I remember sitting in the emergency room. I asked everyone to leave. There were about 25 people. I didn't think a hospital room could hold so many people. And I asked everyone to leave, and everyone knew what I was doing. And I sat there, and I held his hand, and I told him, 3 things about our relationship and thanking him for our friendship. And he said, Charlie, why am I here? The point is he didn't even know that he was dying. And even his wife, on our way to home to take him for hospice, called me up and said, Charlie, go back to the hospital. Chris forgot his Tarceva pill. And I said, Lisa, I don't think he needs that anymore. The point is the system completely failed him. His doctor never said a thing. And that became my launch pad into quality of life matters to patients. And my mission has been to bring patients' quality of life into treatment decisions. And the best way to do that and how I'm achieving that is through data, getting patients to track their quality of life so they can make the best decisions for themselves.
All right, we'll be right back with Charlie Coltman.
Are you looking for a new job or want a career change? Look no further than Monster.com. Need a little help standing out? Our expert resume writing services will make sure you shine. Want to brush up on your interview skills? Engage with our AI interview prep tool. Want some advice on negotiating your new salary? Visit our salary tools and extensive library of career advice articles, and you'll have all the tips and tricks you'll need to succeed. Visit Monster.com today and take the first step towards your career. Monster.com. Find your right job fit.
All right, we're back. I was digging through your the litany of all things Charlie, and I saw that you did varsity soccer.
Oh, absolutely.
What did that mean to you as a kid?
That's a great question. It meant everything to me. I had no friends when I was in 3rd, 4th, and 5th grade. It was incredibly lonely, but I was a kick-ass athlete. Kickball, I was left-footed because my dad sort of forced me to play with my left foot because he said, you need to learn your left foot. And it basically became my dominant foot. So I'm right-handed, but left-footed.
Wow.
That's an interesting fact. So that might be our code word.
That's our fun fact of the day.
Right. But the point is, at that time, the best way that I felt good about myself was scoring a fucking goal. And so soccer was my best sport.
Did that drive you into the whole sales business, the validation of the win?
Oh my God, Jesus Christ! Matthew Zachary, PhD,
I've been doing this a while.
Man of mystery, and psychologist. No, yeah, that absolutely. In fact, it so much so that whenever I started a new sales job, I looked at what the top salesperson made, and I went for him. And I said the best way to do that in technology is where I've gone. I started SAP. I worked for Ariba. These are large IT systems, $2 to $5 million a pop. And what I would do is take the technology into a new industry, because if you can own an industry, you can sell a lot of it. So that was kind of my goal. Is I would always go where the sales manager didn't want me to go, because what do they want? They want transactions, close, and I'm like, I was always going for the golden goose deal.
Yeah. So you never fancied yourself a health entrepreneur until it landed on you with the loss of your friend.
Yes. Well, actually, my first sales job was selling billing systems to doctors in the mid-'90s. So,
oh wow.
So that was literally my first cold calling, and I learned the secret pitch to sell to a doctor in healthcare, especially when it comes to his practice. I remember a surgeon came in, I'm waiting in the waiting room. I'm 2 years old, and I'm waiting in the waiting room, and he's just come back from surgery. He looks like literally like he's got blood on his sleeve. And he goes, "I'm exhausted. You've got 1 minute to tell me why I need this." Meaning, why do I need a billing system? I just said, there's 2 reasons, Doc. Get paid faster. Your girls won't complain as much. He goes, I'll call you tomorrow.
They got to see their dad. Yeah, you could be a dad. Yeah.
Exactly.
We know that all too well.
Well, his girls, I met actually his billing managers, right? The folks, the administrative staff.
The staff girls. Yeah.
So, yeah.
Is that sexist these days?
Probably.
We're going to get canceled for saying
Listen,
that.
folks, it was 1996.
Friends was on. It was a different world.
It was. Nirvana was still hot.
Yeah.
But
6 white people in a rent-controlled apartment.
But Kurt Cobain was dead. So
yeah, that is true. That is true. So, yeah, I mean, this whole idea of how do I make things suck less? Would you agree that I like to say the healthcare system isn't broken, it's built by design, and it's the responsibility of the citizens of the country to bend it to our will? How do you feel about that?
Well, I absolutely agree. I mean, the fundamental question you have to ask when you're inside of healthcare, and especially on the entrepreneurial side, right? We're both entrepreneurs. We're trying to figure out how to build a business. The first question is, who's paying?
Right.
Someone is paying. Is it the doctor paying to deliver care? Is the payer? Is the insurance company going to pay? Is the pharmaceutical company pay?
Is the patient going to pay?
Is the patient going to pay? Who pays, right? So the problem is, even if you have the best system in the world, if you can't answer that question or target it, because ultimately the healthcare system, here's one for you that I thought about a couple of years ago. The healthcare system, when it comes to paying for care, is basically your 3 college fraternity brothers who don't have jobs. When the bill comes and everyone's partying and the bill comes and they plop it down on the table,
right?
Everyone's pointing at each other, going, "He's paying." So inadvertently, you get thrown around, right? Because everyone says, "Why should I pay?" And so it's like trying to pay for a check with a big group, brunch.
It's ridiculous.
Who's paying? Who's paying? So yeah, the system remember, keep in mind, it's also the most advanced healthcare system in the world. We can all say that we want nationalized healthcare, but try to get a colonoscopy without Cologuard because that's not approved in the NIH, and
Right.
it takes 9 months, and you might be bleeding blood, and they're still not going to take you.
Right.
So, I don't know if that's necessarily the answer, but I think the bottom line is the best way that patients can unite is really through data. That's what doctors know.
Yeah, but is that really fair, right? We talk about how, the average person in crisis or in post-traumatic crisis may or may not be able to have critical decision-making skills at that point. And you're dependent or reliant on a Walmart greeter in the shit happens store that doesn't exist.
The other side of this is because of the lack of trust in the system, in their doctors.
Trust.
The doctors are not, my doctor doesn't listen to me. Half of medical advice coming from a doctor is not followed, right? Medical adherence is a huge problem.
It's dismal, yeah.
So trust is an issue, and I guess all those conspiracy theories that are out there doesn't help either.
Yeah, that fucking moon landing, I swear to God. What were they thinking?
Yeah, I don't believe that cancer has been invented by the pharmaceutical industry, nor do I think there's a secret cure in a secret basement. I think I think the cure.
I've been to that basement, by the way.
Really?
Yeah.
Is that where
It's made of adamantium and whatever Wakanda
and
does.
the KFC recipe is also in there? Colonel Sanders.
I always say that, there are plenty of pharma executives that do very well, but their kids also die from cancer. And if there was a cure in a jar, it would probably be out there already.
Well, I mean, it's a series of breakthroughs, right? I mean, the unsung heroes are all the folks that have literally spent 10 years. I mean, let's use COVID as an example. The point is Moderna, they didn't all of a sudden invent it. They weren't like, oh, well, you have to, they were working on this for 10 years.
Well, mRNA, people don't even realize this.
Oh, my God. Yeah, well, let's talk about that. I mean, that's like the penicillin of our generation.
Yeah.
And they just announced their partnership with Merck saying, we think we have, indications of a cancer vaccine.
Right.
The point is, it's 10,000 really hard, dedicated workers spending over 20 years that are making those incremental breakthroughs in treatment for cancer.
Well, that's the overnight success that took 2 decades.
Yes, you're right. That's the famous comedian said that, right?
Yep. Mm-hmm.
Jackie
Mason.
Jackie Mason, yes.
I think so.
Absolutely.
We're going all full Jewish here with our space lasers and everything.
That's it.
All right, so let's get to your product. Let's get to, you channeled all of this into something that we hope is making a difference. I'll predicate this by saying that back in 2012 at Stupid Cancer, my co-founder Kenny and I had this idea of, it was way ahead of its time, Tinder for cancer. That was our idea. Can there be a dating app for cancer patients to meet each other? There was no Grindr. There was nothing that matched communities with communities at the time. I mean,
there was just Craigslist.
There was like I think JDate was still on a website at that point. Now Match.com was still a website. There was no whatever those. There were no apps.
No, there was no online dating. There was only happy hour still.
Right, but it was basically just, what does peer-to-peer mean on a platform? And what the nonprofits did was they introduced you to a club you didn't want to be a part of, but you're glad you're there. And that was the idea behind, can we do this on an iPhone 4?
Right.
Whatever it was back then. And
yours was text-based too, I remember.
It was a pure text app. Instapeer was a pure text-based app. It did nothing but instant messaging with other members. And we couldn't scale it as a charity. It was a great idea as a proof of concept. And it eventually buzzed out and fizzled out. But it led to this idea of we were ahead of our time, but now we're at a prime time where this idea, this model of peer-to-peer connection, but with more depth and breadth from a user experience, can actually help people live better lives. Talk to us about your product.
So my product is called Cancer Life. Let me talk the first part of my journey. I immediately start building, which is usually a mistake, but my idea was to do remote patient monitoring. So wouldn't it be great if, and whenever you walk into cancer, you walk in with the idea that, idealistic, I'm going to change it all. Well, I did. We had a pilot at Frederick Cancer Center immediately. I mean, it was within the first 6 weeks, I had some director, Mark Soberman, who's a fabulous guy, who just came out of Georgetown Business School, and it was he was so patient-centric. So small little cancer center, decisions were easy to be made. We did a pilot. 21 patients signed up, and they basically used Cancer Life in our first Indian-based, international, cheap-based software technology.
Yeah, we used an India company. Minimally viable product. Worked.
Yeah, listen, let's just say that if coding is an art form, they're the finger painting of coders. They can get you a product and they can show it in front of your class to your parents. But believe me, it's not something you want to put in the exhibit.
There's a billion of them
And
listening to the show, by the way.
Well, good. Listen, you guys need some actual formal training, not just going on GitHub and
boy.
learning, anyway. My point is, we did do a pilot. And the issue was the patients loved it. We had letters being written to the director. This is the greatest system. Essentially what Cancer Life is you share using emojis and icons how you're feeling, list your symptoms, and you share it in a social network, and you could get your friends and family to comment. So it was kind of like CaringBridge meets data collection.
CaringBridge. Wow. Are they still around?
I don't know.
Okay.
I believe me. I've tried
That's a great elevator pitch, though.
Well, they had the first system. They, to their credit, the first online social network was used with cancer patients that they could say, hey, get all my friends and family when there's a major update. But unfortunately with CaringBridge, you're not going to use it for the day-to-day purpose. You're only going to do it every 6 months when, there's usually good news. And you don't want to use it when there's bad news.
Right.
Because there's shitstorm that follows, right? Everyone shows at your house and bringing flowers and anyway, I digress. But the point is we did a pilot, and that's called remote patient monitoring, where the actual cancer center would buy the system and they would interact with patients. Well, there's a problem is this, and it goes to who pays. Do you know that 40% of the cost of delivering care, meaning the revenue that is generated by the cancer center, because cancer centers are the number one profitable center in an actual hospital, 40% of that revenue is actually gotten in the emergency room. It's the treatment and it's the doctor billing, but it's also the emergency room. So I'm trying to actually improve that, and I'm walking at cancer centers in 2012, 13, and 14 going, I can lower your emergency room visits. And I had an administrator pull me aside and said, I don't want to do that.
Right, because it's going to cost them.
They're going to lose revenue.
Thank you for using my words against me.
No, I mean, and that became the rub. And I said, a cancer center has a disincentive to lower their emergency room visits.
Right.
Again, this is 2012. In terms of where we are in terms of value-based care and all this other stuff.
Right.
I could talk about that for an hour. But the bottom line is that was a realization that I wasn't going to win that battle. The other thing, and this just goes to everything healthcare. Anyone here who's listening that may have a healthcare startup, do not disrupt the workflow of the doctor. In cancer specifically, and that was the other realization, as cancer moves to genetic testing of tissue profiling, and those companies need to do a 10 times better job, and there's going to be a whole wave of innovation around that. Doctors literally are paging through 12 pages, PDF pages, to try to figure out what type of genetic marker is this and what drug do I need. It's
keeping up.
It's 40, and then I have to enter all that information into literally a doctor, like world-class doctor, is spending 45 minutes per patient probably every 2 weeks entering all that data. The point is, don't disrupt their workflow. They're really busy.
Right.
Do they really want to be messaging patients? And when we did the final kickoff meeting of our pilot, I saw the look on the head nurse's face. When she said, what next? I said, well, let's roll this out to everyone. And she looked at me like I just pissed in her punch bowl.
Oh, boy.
And that face is burned in my brain. And I said, the cancer centers, as much as they would love to, don't have time. They don't have the IT staff. They're not going to be able to implement these systems. And to this day, almost 10 years later, there are 2 or 3 companies that are out there right now. And between all of them, they got less than 5 cancer centers implementing remote patient monitoring in cancer care.
So does that explain why this is billed as a consumer product?
Correct, exactly. So in 2017, I threw out all my...
I mean, billed like paid for, like it's being marketed as a consumer product.
Yeah, and my goal was in 2017, I just decided 2 things. 1, throw out all the software code, build it from scratch. 2, this needed to be direct to patients. And I needed to validate it. That was the other thing. I saw how digital health was going. If I can't prove it to patients and doctors that this app actually, in a validated way, and we'll talk about what validated means, in a meaningful way improves quality of life, then guess what? I'm just going to be another cancer app. The 10,000 other ones that are out there that I'm sure Matthew Zachary has seen or heard about over the years.
There are a lot of them.
Right. And so my point was I needed to start over. And so I decided to run a fully randomized control trial on Cancer Life to improve quality of life. And we just completed that study, and we'll be publishing our results. But we've had them validated through a third party called the Validation Institute, ironically. And
Who named that?
well, I guess they were going for what we do.
It's
right?
the same people that named the walkie-talkie.
Instead of Nike, it should be like the best freaking shoes in the country.
Right, exactly.
But the point is, we ran a fully randomized 2-arm controlled study. That means the same study design that a pharmaceutical company would use to get FDA approval on their drug, we ran the same thing. And the results are we raised quality of life by 14.3% per patient and most importantly, reduced their symptom burden of each patient by 66%.
All right, we're going to take another quick break and then a quick epilogue with Charlie because this is cool stuff and it's really important that we get as much out of this as possible. All right, you had me at evidence-based app.
Yeah.
The whole idea, first of all, evidence-based, most people hopefully know what this means, is like it actually works. You can track how it works. You can measure how it works. You know that by doing this, the trajectory of someone's behavior has changed for good.
Right.
And you've made it suck less clinically.
Right.
How does a bill become a law? How do you get an app to be evidence-based when it's not clinical? And then what does that mean for its potential to eventually become something that is paid for and given to everyone by a doctor? Because distribution is very limited.
So I think we are in a crossroads. Not many digital health companies have done fully validated studies, right? So it depends on the level and quality of the study that you're running, and you want to hit that level of therapeutic, and you want to get FDA approval. The problem is there's no billing codes for a doctor to prescribe them, and then us, the app company, get paid. So there needs to be a bill that's passed. I think literally last week they were on the Capitol Hill. There is a bill that is going to, try to legalize this to get app companies, so long as they've run and they've got FDA approval and they've shown validation at the highest level. Eventually, this market will be formed.
So if it's not approved and there's no billing code, doctors don't care about it.
Well, first of all, doctors care about it if doctors will care if they know that their patients are going to benefit, and patients are going to benefit if there is a validated study with published results that they can click onto. And that's kind of where I am, is that publishing those results to convince oncologists that we could raise quality of life and lower symptom burden, which only helps them from their quality perspective.
Right, because you're looking at what is the adoption model. I'm sure it'd be much easier if it's reimbursable.
Oh, well, of course. Yeah. I mean, there's kind of two revenue models of the company. One is data, right? So we're collecting long-term patient-reported outcomes that we discussed. That de-identified data, we can run phase 4 expansion studies as well as, more importantly, safety studies. So these studies are required by the FDA. When you get an accelerated approval by the FDA, they say, that's fine. However, you better run studies to make sure that this is not impacting patients. You had 30 patients in your clinical trial. You want to roll this out to 30,000. Let's see how they're doing. So if there's a platform that's collecting that data, we can run those studies virtually so that patients can literally one click, sign up, contribute their data, de-identified, and move on. And that's sort of the foundation of our revenue model. Phase 2, as these legislation gets finalized and there's actually a reimbursable code that a doctor could then prescribe Cancer Life, that's also where it's headed. But we still have a little bit of time, a couple of years before that's true.
All right, last question. I always talk about the oh shit window. When you find out something bad has happened to you, and then when whatever needs to happen to you because of that bad thing starts to happen. And it could be a day, a week, a month. And who is protecting that poor citizen, that consumer in that moment, by making them aware of things they never thought to look for in a supply-only economy? In an ideal setting, how would that cancer patient be made aware of your product in a trustworthy way that would make them adopt it right then and there?
Right. So we're talking about distribution strategy and, how is the patient introduced? And I think for me, it's been a challenge to find those partners. I think at this stage it's partner. It could be a nonprofit. There are several of them out, and they have existing patients. where they're, patients tell patients. We know that, right? And if, one of my strategies is to suggest if it's a validated product and the quality is there, who wouldn't want to raise their quality of life, right? Number one. Number two, there are other partner companies that I'm identifying that are in those moments when they are the ones delivering the information. They're genetics companies. The oncotype score of, am I going to respond to the treatment? Those companies exist, and I think they're an interesting partnership. So for me, at this stage, it's really through a partnership model.
Well, we both agree that every patient deserves to know shit exists that they never thought they'd need, and that it's almost like a liberty. Entitlement, that why wouldn't you want to know that there's something there that can help you? Charlie Coltman, Varsity Soccer Philly Mensch, and the CEO and founder of Cancer Life. Thank you for coming on the show.
Thank you, Matthew.
Out of Patients with Matthew Zachary is an Off-Script Health production. The executive producers are Matthew Zachary and Andrew McDowell. It's mixed and edited by Kyle Moore. If you like the show, ratings and reviews are always welcome. Leave us a message anytime at 855-AUDIO-66. That's 855-AUDIO-66 to share your healthcare shitness with us, and we might just play them on the air on a future episode. For more information about this show and Off-Script Health, visit offscript.com. That's offscript, no T.com.